Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Danny.
And I'm Leo. In today's episode, our guests are Joshua Johnson, Sandra Passek, and Brittany Lapin. Today, we discuss our article featured in the Physical Therapy and Rehabilitation Journal.
We discuss their research and teamwork, predictive models in acute PT, and the phrase, "It depends." Enjoy the show.
Okay, we are live. Welcome to Acute Conversations, the official podcast of APTA Acute Care. And today, we've got special guests. We have authors from the journal article, Development and Validation of PT Pencil, PT Frequency Clinical Decision Support Tool to Increase Hospital Discharge to Home. So we've got Josh, Brittany, and Sandy who are part of this research. And thank you all for being here today.
Thanks for having us, Leo and Danny.
Appreciate the invite.
So the first question I have is just, what were your different roles in coming together for this research?
I'll start because this was probably my crazy idea initially, and then I needed a lot of help to try to pull it off. I was fortunate to be a scholar with LEARN, the Learning Health System Rehabilitation Research Network that Dr. Linda Resnick runs out of Brown. And I worked on a mentored project with Dr. Janet Freeberger from Pitt, where we examined at Cleveland Clinic the relationship between the frequency of PT visits for hospitalized patients and whether those patients improved their function and discharged home. So that was a fun study where we found that generally there was this dose response curve that showed that if patients got more frequent therapy while they were hospitalized, they were more likely to achieve either or both of those outcomes. But we recognized that it wasn't true that every patient needs more PT. And more than that, it's definitely not feasible that every patient in the hospital would get PT or more PT. And so while those findings were interesting, I really wanted to find something that would actually help clinicians make decisions about who would benefit most from those services, who really needed those more frequent PT visits, because we know that it is not everybody, and we don't have great evidence to suggest who does and doesn't benefit. I'm going to shout out my colleague, Valerie Asp, who is one of the physical therapists at Cleveland Clinic, who was a research assistant on that initial LEARN-funded study. She and I were sitting in my office one day, and I said to her, I have this crazy idea, and I need you to tell me if it's dumb. And I told her about this thought of creating a tool that we could put in the electronic health record, essentially to help therapists triage who they should see on a given day or what frequency they might set for a plan of care when they initiate a patient's treatment in the hospital. And thankfully, after thinking about it for a second, she said, no, that's not a dumb idea. And she said something that really helped me frame this. She said, if we can do that, then it empowers me as a clinician at the bedside to think about what am I doing at the bedside instead of spending so much time just trying to decide who to get to, which eats up so much of my day in the hospital. Yeah. And so she loved the idea of having the autonomy to think about interventions at the bedside and having guidance about which patients would benefit from those things. So from there, we just started. We thought about ways to pull this together. Brittany's a biostatistician with whom we worked extensively, and I realized we needed her expertise to help us build a prediction model that would help identify those patients. And then Sandy runs bioinformatics for rehab services at Cleveland Clinic, and so we would need her expertise to think about the quality of the data, where those data live within the electronic health record, how to get them out efficiently, who to partner with to get this thing built. So we just started pulling a team together. So the three of us plus several clinicians and rehab managers from 3 different hospitals at Cleveland Clinic, where we decided we wanted to run this. And unfortunately, we actually got funding to do that work again from LEARN as a pilot trial. So shout out to Linda and LEARN for continuing the support of that work.
Awesome. And then just also shout out to Brittany, because as we were coordinating this all together, Brittany had let me know that she actually got her, so both your master's and your PhD from University of Illinois School of Public Health. So it's great to see that connection there. Yes, absolutely. So I remember a couple of years back, Josh, you were at, I think it was CSM. I remember hearing this. I went to one of your talks, PT Pencil. I'm like, okay. And you're like, yeah, the acronym is in there somewhere. Don't worry about it. But this is what we have. thank you so much for putting this research out there, because it's the age-old question. A lot of our listeners are either students and clinicians that are working bedside. And what do we usually do? It's kind of like, all right, this is what we've traditionally done. We see the orthos, BID usually, and anyone that is, if they don't have insurance or if they're a stroke, at least in the institutions I've worked at, they're the priority. They get seen every day. And then everyone else gets triaged, whether just on the coffin, spending time trying to figure out who am I going to get to, because there's 20 patients that I could see, but I only have the bandwidth to maybe fit in 8. So how do I prioritize? Who do I see once a week, 3 times a week? So then I see this was featured in the actual PT journal. So great that acute care is getting featured in our main PT journal. So thank you for that as well. Could you talk maybe a little bit about like some of the roadblocks that came in your way in terms of putting this study together?
Yeah, before I do, I need to correct myself. I shouted out to Valerie, who was instrumental in helping us with this. But that initial conversation I had, I'm remembering now, was actually with Kelly Adams. Self-correction. Thank you to Kelly, and apologies for misremembering that initially. That's an obstacle in my own memory, for sure. There were a lot, and maybe I'll start first, Leo, with your reference to the name of the tool, the PT pencil. So this was originally called, as it is titled in the journal article, the Physical Therapy Frequency Clinical Decision Support Tool. We named that before we really started working on it. And the expectation was that we would be able to help therapists conceptualize an initial plan of care frequency, which we know in most hospitals has to happen. I complete my evaluation, I set a plan of care for 1 time a week, 3 times a week, 5 times a week, daily, whatever it might be. So that's what we thought we were going to help clinicians do. But then once we started the work and we were meeting with this group of clinicians and managers from these 3 hospitals and understanding a little bit more about the exact way they think about that decision and who they see as they show up each morning, the exact things that they think about when they're making that decision, things like what's their prior level of function, what's their current level of function, how much help do they have at home, what do I expect their functional prognosis to be given their diagnosis, how much help do I have from other people to keep this patient mobile while they're hospitalized. All those things go into their head. We looked at a new set of variables, and then Brittany would go back and run new analyses for a separate prediction model. And through that process, we determined that we really can't help therapists set a frequency at the outset of a patient's hospitalization. The best thing we could do, and what we felt like really was the most appropriate thing to do, was help therapists recognize which patients they needed to see the next day. Mm-hmm. In the discussion of this paper, we actually renamed the tool. So moving forward, you won't see the frequency reference anymore. It'll be the physical therapy plan for next session clinical decision support tool. We had to keep PT pencil in there. So just like before, Leo, all of the letters are in there somewhere to create that. But it's really what it is helping the therapist think or get a flag that helps them recognize this is a patient who's potentially going to benefit from therapy today or tomorrow, depending on when they're viewing the tool. So that was one thing. Another big thing that we struggled with, and then I'll ask Brittany and Sandy to chime in as well from things that they recollect. We really struggled with which outcome to predict. The model has to predict an outcome to work. We had to define benefit, essentially. We had to say what we mean by benefit, and benefit most from PT services is X outcome. And we initially talked about whether or not that outcome should be discharging patients home. So do I as a PT feel like my interventions are going to be meaningful in helping a patient to avoid a discharge to a post-acute care facility? And sure, we agreed that was probably true, but that wasn't always the only outcome that we were looking to accomplish. It may be optimizing function so that the patient who is still likely to discharge to a facility is at least optimized for the rehab in that facility, so that they're prepared to receive the rehab there. Their length of stay in that facility might be shorter. There are other goals that we work on as PTs that aren't always related to I'm getting this patient home. And so we struggle with that decision. But 2 things I think really helped us feel comfortable with allowing the model to predict that particular outcome. One was with senior leadership support from Cleveland Clinic to do it that way. So the year that we developed this, Cleveland Clinic actually had one of their top 10 operational drive metrics to discharge more patients home and fewer patients to facilities. So our rehab directors were saying, we want to influence that outcome as therapists. So that helped us. And then, like I said, we had gathered a group of clinicians, bedside therapists and their managers, and we asked them, and we talked extensively about the different outcomes that they aim to accomplish when they are treating patients. And they all helped us feel comfortable that, yes, discharge home is the thing that I think would move the needle the most in terms of helping me decide who I should see or shouldn't see. It's not the only outcome I'm going to focus on, but if the model is going to predict an outcome, it should be that.
As you were talking about creating this and setting it up, you mentioned getting data that you can use to create these models. So Brittany's work can't happen without good data. And Sandy, correct me if I'm wrong, but that was the role you were playing, right? Was helping to identify where we can get this information. I wonder if you could just reflect a little bit on, because I think sometimes clinicians document and they feel like no one ever looks at this again. Document, it's useless. Unless we get sued or or Joint Commission shows up, no one's going to ever see this. So I wonder if you could just talk a little bit about the value of good documentation, what good documentation looks like that can help with this kind of thing, and what maybe less helpful documentation looks like, and how that contributed to your ability to do this together.
Yeah, that's a great question. And it's something that is like on the forefront of what I do every day, is really looking at that documentation. And then what does that mean for us on the backside when we look at reporting, et cetera. So with this project, or with this idea that Josh had, I think probably one of the biggest thing, the most important pieces of it was that engagement with the clinical teams. And so Josh uses the word learning communities with the therapists that are on the front end of who would be using these tools. And we were able to work with them and help to identify what those pieces were and where they lit, where we were gathering that data within the medical record, and then helping to build that tool, just really making sure that they understood the importance of the information that they put into the medical record was then going to drive this tool and work that algorithm in the backside to give us the information that we need. So I think that was really important. And then probably the other most important piece about that learning community, just to take it a step further, was really looking at where this tool would be available to them in their workflow in the electronic medical record. So just so that they see the value of it, and that it wasn't going to be additional work on their part to give us the data that we needed. We did ask them for one additional piece of information along the way, just to help us to evaluate the tool. But they were, because we looked to make it so efficient for them on the front end of using the tool, they were willing to help us get that extra piece of information.
I love that point, Sandy. I appreciate you bringing that up. I just want to reiterate the important role of that learning community and the importance that we kept bringing back within those discussions to make sure that we created something that was truly helpful and not a hindrance, because documentation is already a burden. And so we wanted to embed it, as Sandy said, directly into the workflow. So that's a point worth reiterating.
And on the data analysis side, Brittany, what were the data elements that were most often missing or in error that you had to, because anytime you're dealing with medical records data, as a data analyst, you've got to deal with that challenge. Where do you see that maybe clinicians could be more thoughtful or consistent in a way that would help with future projects or at other institutions that would prevent data from being missing or from not being as useful as it could be for you?
I was very lucky in that Josh did most of the data cleaning of these variables for me. So he pulled, so stairs at home was one of the important variables, and how that's captured is challenging to clean and code into. We ended up using a yes, no, or missing category. So I know that was challenging. And then also how prior level of function was captured and encoded was challenging. With all of those PT entered variables, though, we did include a missing category. And I think we ended up getting pretty lucky with those. And only about 3 to 5% of the patients had missing data in those areas, which I know is an issue when we're trying to apply this in other hospital settings. But those PT level variables are difficult.
And I would just add to that real quick that that was a consideration as well when we were building the model. We wanted to make sure that we we're including variables in the model that were collected relatively regularly and consistently. And credit to Sandy and the rest of the Cleveland Clinic Rehab leadership team that had been baked into the process. So we pulled data from 11 Cleveland Clinic hospitals, and in all 11 of those hospitals, all the acute care therapists document the exact same way, essentially, especially for the variables that we needed. However, we were missing variables that the therapists thought were important. So things like cognition is not collected in a standardized way in acute care hospitals, including in those hospitals where we pulled data to build this model. And while the clinicians thought their current cognitive status would certainly influence whether or not they are appropriate for therapy, we couldn't include that in the model because we didn't have a standardized way to look at that.
Yeah, I think for our audience, anytime you are considering changes to your documentation and to the medical record, work with experts like Sandy and Brittany to make sure that the changes you make will allow you to do things down the road that you might not even be thinking of right now. What are the ways of documenting that will allow us to use these data in ways that are more powerful than just having a written record of what we did in the past, but something we could actually use to analyze and to drive better practice in the future? If you don't talk to folks like this, you probably won't design your medical record in a way that will allow you to do that in the future. And it's a missed opportunity when you don't.
Yeah, I think that's a great point that you just made, Danny. And I think it's a good shout out for all future projects or ideas that come into play. Just going back to what Josh said. So the cognition piece, it's a prime example of that, right? Is that how the clinicians want to document it in the electronic medical record isn't necessarily the best way for us to pull it out and utilize it in a statistical model like this. So I think that's just a really good point that you made.
And there were also issues like how things are collected change over time, over years. So on the back end, when the data pullers were pulling it, they wouldn't always find it. And then I wouldn't know as the analyst that data are missing unless we look at actually like frequency counts and missingness. So there was a lot of back and forth. And we really have to pay very close attention to data when you're capturing it over multiple years.
Mm-hmm. That speaks to what Danny, you just said, is those updates that are made to the electronic medical record over time.
Can you all talk a little bit about some of the other variables? Because I remember reading through the article, there were other variables and how those were chosen. For example, like you guys said, stairs, score on the Boston unpack, I think, and then during the hospital stay. There was possible caregivers, prior level of function. You talk maybe about some of those other variables that came into play with being utilized for PT Pencil.
Yeah, so the key variables that ended up in the model, and again, this was really an iterative process where we would ask the clinicians in our learning community what they evaluated. What's the calculus you do in your brain when you're thinking about the ability to set a plan of care frequency or determine appropriateness of a visit and whether the patient can discharge home or not, with the combined aspect of Brittany then taking what the therapists were talking about in their brain and actually running those numbers. So we constantly iterated on this and ended up settling on a model that we feel like is both clinically representative because so many clinicians weighed in on it, but also statistically appropriate because Brittany ran those analyses appropriately. So the variables specifically are age, whether or not the patient had surgery during admission, as you mentioned, Leo, the unpack 6-clicks mobility categories. We did categorize that, and people are welcome to look at the paper to see exactly how we did that. Patient's living environment, and Leo, this is your point. Do they have a caregiver at home or do they not? And then with that caregiver, how much help do they have available to them when they discharge home? Do they have no help available, occasional help available? And then whether they have stairs to get into the house, and then finally their pre-hospital level of function. And we categorize that as well, because that was one of those variables that in the documentation was a bit messy. And so we had to decide how to recode that. And we ended up being able to do that just based on whether or not the patient needs assistance with ADLs, IADLs, or if they're independent with both. So again, to your question about how did we settle on those, it really was this ability to iterate over time, over multiple meetings with this learning community that Sandy referenced, and Brittany's ability to check that using the statistical modeling skills that she has. And hopefully you, Leo and Danny, you're both acute care experts. Hopefully you and the listeners would agree that those are variables that matter when you think about, should I see this patient and can they go home?
But also just to bring up one other unexpected issue with this analysis is we initially wanted to identify those patients who differentially improved based on physical therapy. So that to a statistician interaction terms between P2 frequency and all the variables in your model. But we had so much data, there were a lot of significant interactions, and looking at those, they weren't meaningful. And really what we found is that everybody benefits from PT. And so that ended up having a lot of discussions with the learning community about how do we then flag patients based on like clinically driven decisions rather than just the statistical model. So there was a lot of reliance on the PTs to help identify those patients.
Yeah, one of my biggest criticisms of observational research when it comes into journals that I review for is that they select model variables based simply on statistical significance. This was a significant predictor in a univariate model or something. That's not how you pick these variables. You have to look at the clinical relationship between those variables and the outcome and the potential for them to influence that, even if you can't detect a statistical relationship in different ways, that you've got to have this learning community with clinicians who understand what's happening with patients to be able to do that properly. So I appreciate that point.
Yeah, and Brittany, you've extended the conversation because the prediction model is one thing, but all the prediction gives you is a probability that patient will discharge home versus to a facility. And so to Brittany's point, what the clinicians really needed to decide is what probabilities matter. Right? If a patient's 80%, if the predicted probability is that patient's 80% likely to go home, should we prioritize them to make sure we get them to 100%? What if a patient's only 20% likely to go home based on their current status? Should we prioritize them to get that up and hope we can make it? And so what we decided to really do is settle right in the middle. Those patients who were maybe on the fence of being able to discharge to a facility or not, or discharge to a facility versus home, because we felt where hospital length of stay is relatively short, therapists don't get a lot of touches for these patients. Maybe it is just those 2, 3, 4 touches that make the difference and get that patient off the fence and on the home side instead of on the facility side. And the nice thing about this model is because we were able to build it directly into the electronic health record, it updates automatically. So as a patient's status changes, so for example, and the variable most likely to change is their unpack 6-fix mobility score. As that changes, the model will recalibrate and say, okay, now their probability is, and then the therapist then gets to make a decision from that point.
To follow up on this whole model thing, Josh, I think the very first time you presented some of this publicly at CSM, a platform presentation I went to, and I asked this question that you're going to anticipate, but I think it's worth discussing a little bit more here. And then I've got one follow-up to it. And that is, with these models based on historic data, they just help us to know what did happen in the past. When we were in Houston, I remember we were walking home or back to our hotel after dinner, and we were talking about this very thing as a follow-up to that. What makes you confident that this model is a good indicator of what we should do rather than just what we did do in the past? I think, Brittany, you could probably speak to that a little bit too.
Danny, you have too much context from all of our one-on-one conversations over the many years. So thanks for the hard question. But you're absolutely right. We do acknowledge that as the primary limitation of this. When you do a model like this, you are using data about what did happen, to your point. And that's not necessarily what should have happened, right? So a patient may have been seen daily, but maybe they didn't need to be seen daily. And yet the model's picking up, oh, the patient who had this unpack 6-fix score and this amount of help at home was seen daily and they went home. So now that trains the model to think that's the type of patient who should be seen daily in order to go home. And that's certainly a limitation of this approach and why we need to do more prospective research to understand, does this, as Brittany pointed out, actually differentially identify patients who do benefit most? There are still, as well as Brittany did in doing the statistical analysis, there are just limitations in using retrospective data, and that is one of them. And so we recognize the need to continue to iterate on this, identify additional variables, really test it prospectively to make sure that it's working appropriately. Brittany, please add anything that you think is useful.
Yeah, I was just going to say, as part of that, that is the biggest limitation. We don't know if patients receive the optimal amount of PT. So again, we really relied on the therapist to tell us which variables are important. And then we also looked at things like if a patient's 6 clicks or impact score increased, does that improve the discharge to home if they receive more PT? So we looked at a lot of different iterations to try to determine if our data was showing us the optimal PT frequency.
And my follow-up on that was something that I told you off before we were recording that I was thinking about today, and that is life and these models reflect real life, and that is small changes in things that we do can have a big effect on, what ends up happening. And mathematically, we can calculate that in terms of probabilities. Like the probability that someone goes home is a certain number, and it depends on the level of all these other values that we put into these models, and little tweaks could change that. And I think, and Brittany, I think you can probably speak to this, but I'd be happy to hear anyone else's comments, is that these models, even though they don't tell us what should happen, do they allow us to learn something about what could happen, even if it didn't? Isn't that what it's doing? Maybe you can just talk about that a little bit, because I think that's a strength to this rather than a weakness, which is we don't know what should happen. We know it did happen, but what could happen combined with clinical expertise, like that seems like an important link.
Yeah, that's a good point. And I think these models are telling us what could happen. We can look at if we have a given patient with these characteristics, what is their probability of discharge home? If we tweak one thing, if they didn't have surgery, or if their impact score was this instead, we can see what could and what should happen based on the model.
So Danny, you just set up a hypothesis, right? That's exactly what hypothesis is. I'm hypothesizing that this thing could happen, which is why we need to continue to do research with that hypothesis.
Sounds like job security for those of us who do research.
There's always something.
And all of our partners who we can't do the research without.
Exactly. Yeah,
Sure.
well, obviously we can't do it without all of the team.
Danny, you had mentioned the most favorite line of PT students, right? It depends. A lot of these things depend from a day-to-day basis, and even just the clinicians. And the longer that you've been in this game, you're like, yeah, I'm okay with it depends, because, all right, let's see what happens today. Like when I literally come up to the patient, yesterday they did fantastic. Today, depends on how they show up, like which patient is going to show up today. So what I really appreciate is how diligent you all were with really getting buy-in from the learning community and the clinicians using for. So what would you tell in terms of our listeners? What would be some of the good reasons for them to read this article? What are the things they can pick up? Just listening to you talk, the prior level of function, sometimes, especially if it's like my 8th patient, the last patient today, maybe there's a little bit of confusion. I don't know if they're really telling the truth, and maybe I'll just I won't take that extra time to really get an idea of what their prior level of function is. Maybe I'm just going to say, can they move around? Let me do my Boston MPAC. Let me do my Johns Hopkins highest level of mobility. Let me do the core outcomes, and not really focus on some of that prior level of function, what their support is like, what their environment is like. And so you're changing my practice and that's part of the reason why I do this, is just to be a better PT and hang out with really cool people. But what would you want your readers to take away from after reading this article?
That's a great question, and everybody's staring at me, so maybe I should start. I think especially for the listeners of this podcast, I'm going to really take a scientific approach and ask that you pick it up and read it and evaluate it critically and see how well we did, because we are not under any assumption that this is perfect at this point. And so we need people who, like you said, Leo, are intelligent and do this often to evaluate that study that we did and poke holes in it to help us think through how to do this better. Because again, our intent was to help therapists in the hospital to consolidate their thinking into an electronic clinical decision support tool so that they can focus on other things that matter in their critical decision making. And we want to continue to develop a tool that does that, and we can't do it in isolation. So even as awesome as our learning community was, we recognize that there's still room for growth. And so I would hope that listeners would find the article, find the holes, the things that we didn't think about, and the things that would help make this better, and help us think through those things and do the work to continue to advance it.
I'll tag along that. I'm just going to reiterate a point that we made earlier, is just really considering yourself a part of the team as you're documenting these patient interactions with these patient treatment sessions or evaluations with your patients, and just really owning that input of the data into the electronic medical record and knowing that it does impact so many things, including projects and tools like this that we've talked about, but just really looking at the accuracy. And I'll go back to what you said, Leo. It's like the end of the day and you're like, I'm not going to focus on that. I'm not going to put that in, but just making sure what you do enter is accurate. You're better off not entering something, but making sure that it is truly a reflection of what the patient, the presentation of the patient. So
I think I would maybe just add, we've talked a lot about individual clinicians and their decisions. We also have some hope that this tool can help managers, right? So one of the motivators for this tool was actually Sandy and I were at the Epic user group meeting back in, 2019, Sandy, I think it was. So. And I learned that there's such a thing called the nurse workload tool. And the way nurses use this is that they, similar to what the PT Pencil does, the electronic health record will evaluate essentially the acuity of a patient's condition to help charge nurses know how sick is this person and how much nursing care are they going to need today. So that way, when they're assigning the nurses that are coming on shift to certain patients, they do that in a way where not a single nurse feels overwhelmed. So I started thinking about that when I heard about that tool in 2019 and thought, well, is there an application of that for physical therapists? And for managers who are helping physical therapists manage their caseloads? Is there a way to allocate the therapists across units in ways where we don't just count the number of patients, but we somehow account for the acuity of that patient's condition in terms of their rehab needs, right? And so I think that's another iteration that we're thinking about, or another, I don't know if it's an iteration or an application of the current version, but we have to explore that. So while we've said a lot about helping individual clinicians make decisions about triage, I also think that there's an opportunity here for managers and leaders to think through, how can I do something like that to support the clinicians that work for me?
Leo, do I have time for one other quick question?
Absolutely. Yeah.
One of the other things that we haven't talked about here, but that you did talk about when you spoke with Stephen George and PTJ about the paper you published there, was about the external validation. And that was one of the reasons that Dr. George wrote an editorial in that edition of the PTJ, was the extra step that you went to validate this in another health system. And I wonder if you could talk a little bit about why you did that, what that adds to what we understand, and then what it took from all of you to make that happen from your partner that you worked with.
I'll start mostly with just an acknowledgement, and Brittany can probably say more about the purpose of the external validation. But yeah, you're absolutely right, Danny. We had great partners. So we partnered with Intermountain Healthcare. Kate Minnick and the team out there were very gracious in recognizing that there's a need to externally validate prediction models like this one to show that this isn't valid just for patients at Cleveland Clinic and the data for the patients that we extracted from our hospitals, but the model is as predictive in other systems as well. And Intermountain is a great partner. They're not close to Cleveland. Their patients are a little bit different, but they collect a lot of the same data in the same ways, in a standardized way. They're very focused on research and academic progress. So appreciate them in partnering with us and providing the data that we needed to be able to really understand how valid this model can be in systems outside of Cleveland clinics.
And it was nice to see that it works well in their data because they had much higher rates of daily PT. So it was a very different kind of sample than ours, and it still seemed to work well.
I was listening to that podcast that you were featured on in terms of PTJ, and what was interesting is how Dr. George had talked about the differences between RCTs. That was a great analogy, how he said RCTs are kind of like your big franchises, right? As opposed to like these predictive models. So what are moving forward now that you had this published, what's in the future for you all in terms of research? And I have a couple other colleagues that I've worked with that's their role, is they're trying to work with big data. They're working with these huge hospital systems across different states and getting this information, which I think is so cool that that's integrating together now. And with the model that you put together in terms of really getting buy-in from the clinicians and working with those learning communities, what's next for you all, or what other aspects of research are you looking into?
So many things, Leo.
Right.
So
Where to begin?
That job security, Josh.
So first, I've already alluded to it. We are interested in doing prospective testing of the model as it currently stands, right? So we're putting it in more hospitals and collecting data to understand, does it actually work? Put it in hospitals, and we've conducted we did conduct one trial at those same 3 hospitals from where we had therapists in our learning community at Cleveland Clinic, and we're working on finalizing the manuscripts that report the findings of that trial. And I'll admit now, it wasn't perfect, right? So we found things about the implementation that made it challenging. It may not as differentiate patients as well as we would like it to, and it may be because of the issues that Danny and Brittany were talking about. So those are things we're going to have to fix. So we're interested in doing that work to make those fixes. We're also cognizant of the fact that while we tried to be pretty general in the types of patients that we included, both in the development of the model, its validation, but also in that prospective trial, we didn't include everybody. So a huge population that we excluded was patients who are currently admitted to an ICU or have an extended ICU stay, because we felt like those patients are a little bit different than a lot of the patients in the hospital. And so we weren't totally confident that this tool and the variables that are included in it would be appropriately predictive in that patient population. And so now we need to go back and check, is it appropriately predictive, or what needs to change for patients in those populations and in others. The other thing that I'm thinking about a lot is, this is the PT pencil, but patients don't go home because just of what PTs do in the hospital. And we're not the only ones responsible for helping patients move in the hospital. Movement, we know, is the thing that really matters for a lot of these patients. And so we're thinking about how to build a similar type of model that is not specific to physical therapists, but could inform an interdisciplinary mobility team and a program in order to help identify patients and direct the appropriate mobility interventions for that patient and the appropriate providers or clinicians who interact with that patient, whether that's nurses, or we're seeing more and more research around mobility technicians, or whether their primary deficits are cognition or activity limitations, where the OT is the most appropriate provider to help get that patient off the fence and on the home side instead of the side. So we're trying to think about how to leverage other types of variables and embed other types of tools that help inform not just the work of PTs, but others as well.
Very cool. Brittany, saying anything else to add?
No, I think Josh said it all.
Yeah, I think that's
All right.
really good.
We're on close to the end of the recording here. So the last thing that we do as part of the podcast is we have a lightning round of just like fast questions, but our questions are very variable. Sometimes they're PT related, sometimes they're completely not PT related. And so I'm going to set the timer up.
I just want to make sure you ask the PT related questions to Brittany.
Okay. Everyone has to answer them. So we're going to set the timer. Since there's 3 of you, we're going to extend the time a little bit longer. But we'll see how this goes. Dan, do you have a question ready?
Yeah, when you're not doing these jobs, what do you like to do for fun? What's the one thing that you do for a good time? Start with Brittany and then Sandy and Josh last.
I watch reality TV.
That's a great admission.
Yep.
I like to be outside, hiking, whatever it be. I like to be outside.
I'm either woodworking, which I'm trying to get better at, or coaching one of my kids' soccer teams.
Very cool. Are you more of a coffee person or a tea person? And then the caveat to that too is, what do you put in your coffee or tea?
Oh,
I have coffee, just
Milk.
Coffee and milk.
coffee black in the morning, but I like my tea in the afternoon.
Nice.
And I drink neither one. It's just water for me to wake up in the morning. I think Andy Reid admitted that recently, so I'll be like him.
That's awesome. What patient population do you enjoy thinking about or working with the most?
as a statistician, I like surgical patients the most because there's a date. There's a pre and there's a post.
You know when it happened.
Yes.
That's a good point.
Yeah.
I like the geriatric population. It doesn't matter what it is. I think there's just a lot to learn from them.
Old people are my favorite too, Sandy.
When I see patients, I'm usually on a neurological floor, and I really enjoy that. But I'll admit a bias that this little bit of time that I've spent in cardiovascular ICUs has been absolutely fascinating. And if I were to do full-time clinical care, I'd want to get trained to really take care of that population.
I get to teach cardiopulmonary rehab this semester, so feel free to join my class. I'm sure you've got lots of free time.
I'm sure it would be good. I'm sure it'd be good, Danny.
Danny, do you have a podcast recommendation for our listeners? Outside of PT Journal, right? And
The one we just did, right?
I only listen to reality TV podcasts, so I
there you go. It doesn't have to be PT related. It doesn't have to be PT related.
No.
That's
Which reality
my
show
podcast.
should we listen to, Brittany?
The Traitors right now on Peacock is the one.
Okay.
But
Shameless.
Survivor 50 is coming out next month, so
Get
stay
ready.
tuned for that. Yeah.
Yeah, I enjoy my in-person reality. I'm not a huge podcast fan or reality TV fan. I just enjoy my time with people.
Good. That's great.
Yeah.
I really enjoy the Freakonomics podcast series, so it's usually what I'll listen to.
Those are great recommendations.
Dan, you want to take us home with our last question?
Yeah, our last question is always, you are in acute care when?
Or we could say acute care research also. We can.
Yeah, that's true, Brittany. You're doing acute care research when?
Oh,
I'll go first, and then maybe we can come back to Brittany. I think you work in acute care when your treatment plan changes 3 times before you make it from the doorway to the edge of the bed.
100% true. Yep.
yeah. And my answer was going along with that. Things change all the time in acute care. You just have to be ready for it. You have to be resilient and just move with it.
Mm-hmm.
There's
Absolutely.
lots of sensitivity analysis with your any studies.
That's right. Multiple sensitivity analyses. Yeah, because so many things could be different. Or what about this? There's a lot of what ifs.
A lot of what ifs. It depends, right?
It depends. You students that are listening to us, you are never going to escape that. But again, as you get better at this, at your jobs and at this profession, you'll appreciate it. Well,
And when you students become researchers, you'll get to team up with people like Brittany and do a ton of sensitivity analyses because
It's a plug. There's so much need for research in acute care. Way to put that in there, Josh.
Yep.
awesome. Josh, Sandy, Brittany, thank you so much for joining us for today for this podcast, and hopefully we'll see you soon. Maybe we'll see you at maybe the next conference, and looking forward to whatever research you all about.
Thank you so much for your time.
Thank you all.
We would like to thank Brittany, Josh, and Sandy for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leo Arguelles and Danny Young. Executive produced by Katie Brito and Edward Mathis. Music by Alexei Action from Pixabay, sound effects also from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for another engaging acute care conversation. Thank you for listening, and may your shoes and scrubs stay clean today.